Hello, everyone. Welcome to another episode of Ocean Rockstars podcast. I'm here, Tom Neymat, with my special guest, Dr. Darmal. Dr. Darmal is a local child and adult psychiatrist, and he's with the Amen clinics. He's had decades of experience dealing with traumatic brain injury, ADHD, mood disorders, and many other mental health disorders. Without any further ado, I'd like just for the audience to get to know you a little bit better. Tell us a little bit about yourself.
Yes, so I'm a child, adult, and adolescent psychiatrist. Currently, I am at the Amen Clinic for the last 17 years. Prior to that, I was professor of psychiatry at John Burns Medical School, that's in Honolulu, Hawaii. I did my training at Albert Einstein Medical School in New York. First, I did my pediatrics residency, and then I did psychiatry, general psychiatry residency. And then I did 2 years of child psychiatry fellowship. So after my training, I went to Hawaii.
Okay.
And so I was a professor of psychiatry in Honolulu for about 14 or 15 years. And then I came to California to the Amen Clinic. One of the reasons was that I was interested in brain imaging. And at that time, Dr. Amen was involved in brain imaging, especially SPECT imaging of the brain, which is a functional brain imaging. So we started working together. He's also a child psychiatrist, as you may know. And so I've been here now 18 years. 60% of my practice is child and adolescent, and 40% I see adult patient also.
Got it. So about 17 years you've been working at Amen Clinics with Dr. Amen, and you guys have been kind of the leading psychiatrists in Orange County as far as brain injuries, brain scanning, imaging, the SPECT imaging that you mentioned. So throughout all this time, how has kind of the treatment of these disorders and the tools that you guys use advanced over the last 17 years?
I think generally psychiatry has changed quite a bit over the past 20 years, I can say. 20 years ago, if I saw a patient, let's say with autism, I was very hopeless. Would most often say that, well, we can't do much. Today, I'm very hopeful about treating a kid with autism and or similar type of developmental disorders. So I think over the years, we have learned quite a bit. And I would say, in general, I'm more hopeful, especially when it comes to children and adolescents. I'm more hopeful for the outcome of the treatment. We have had more positive outcomes. And even in patients with traumatic brain injury, dementia, Alzheimer's disorder, I've had quite a bit of response and success in treating those patients. I think the main issue is to find the etiology or the cause of the disorder. I mean, it could be environmental, it could be genetic, it could be other factors. Once we identify the cause, then treatment is much more easier.
So what are the tools that you have at your disposal now that give you that hope that you can treat autism and other mental health disorders that you didn't have 10, 15 years ago?
Yeah, so I mean, 15 years ago, I would see a patient, and it was my own personal clinical impression that was the main diagnosis. It was based on my personal clinical impression of the patient. Today, we have other tools that we could use. I think diagnostically, the DSM over the years changed quite a bit. So we have a better diagnostic category. But scientifically, beside the DSM, I've learned quite a bit from the brain imaging, just looking into the brain. I give you an example. 20 years ago, I would rarely consider traumatic brain injury as one of the causes for certain disorders, mental illnesses. But today, that's one of the main issues that we have to rule out: brain toxicity, especially because of hypoxia, brain toxicity because of the environmental toxins, substance abuse. All these other factors make a significant difference in treating the patient. I never forget a case of a 12-year-old, this is about 10 years ago, who had seen maybe 9 or 10 different neurologists and psychiatrists, and the treatment was very unsuccessful. And so mom brought this patient to us, and we did one scan. The scan showed that half of the brain of this patient had not developed totally. It's a condition called colpocephaly, where half of the brain doesn't develop. I mean, it was bad news for the patient and the family. But the minute the mom hears what I tell her, that this is the main reason why we are not that successful in our treatment, even though the treatment remained very challenging, the fact that she knew what is the cause made a big difference. She became much more hopeful. And the treatment, we kind of designed a better treatment, and we had some success. Not 100%, but we did have some success. That was just an example.
Yeah, no, that's a great one. I mean, just to be able to have the tools available that can give you hope as a practitioner when you're working with clients and families. So tell us a little bit more about some of the tools that you guys use at Amen Clinics. You mentioned SPECT imaging. I think a lot of people might not be familiar with that. If you can give us, what exactly is SPECT imaging, and how do you use it to treat patients?
It's single photon emission tomography. It's basically a functional brain imaging. We use an isotope. It's a radioactive isotope that is injected to the patient, and within 10-15 minutes, the isotope gets absorbed into the brain cells. And then we look, the patient lies down under the camera, and we take pictures. And we looked at the blood flow in the brain. So those areas of the brain that are more active, they absorb most of the isotope. And the areas that are lazy or damaged or not functioning well or inflamed, they don't light up, and they appear as a dark area. And so that kind of gives us an idea. One other disorder that comes to my mind, sleep apnea. Sleep apnea is a very common disorder, but undiagnosed. I mean, people think that sleep apnea is not a problem in children or adolescents, but they could have a central sleep apnea, or even peripheral factors can contribute to that. Any kind of obstruction in the airway can cause hypoxia to the brain, and when they're sleeping, that lack of oxygen by itself can cause inflammation in the brain. And I can tell you about 20-25% of patients that come in for ADHD, essentially they have sleep apnea.
Wow.
That is contributing to the overall brain development in general, but also the fact that they cannot sleep well, or the sleep is not a restful sleep. The next day they feel totally tired, they can't focus, they can't concentrate. And so I'm seeing that quite often.
So their sleep and the sleep apnea is a significant factor in their ADHD and kind of how they function during the day.
Yeah, I mean, you ask any sleep specialist will tell you this and confirm that half of the patients that come with that are diagnosed with sleep apnea either have a mood disorder or ADHD.
Okay.
Yeah, and so that's another big issue that just ruling out the sleep apnea and treating the sleep apnea by itself makes a significant change. 20 years ago, I didn't have
You
that.
didn't know that, yeah. That's a big advancement, just to be mindful of that and know how to use those tools in order to succeed with the patient.
Yeah, but it's an important tool. I mean, obviously, it's very challenging to look inside the brain.
Right.
I mean, we don't have tools like maybe the CT scan will only give us an idea about bleeding or something like that. MRI will give us some idea about the shape of the brain or the structure of the brain. But for the function of the brain, we have very limited tools.
Right.
SPECT is one of the tools that we have, which is safe, not that expensive, but gives us a lot of information.
Is that tool, the SPECT tool, is that useful for clients dealing with addiction or other mental health disorders, or is it for a very specific type of mental health issues?
No, in patients with addictions and substance abuse, it's a good tool to give the patient an insight that this is where you are, or this is how much you have damaged your brain, and this is what will happen if you don't do anything about it.
Right.
Them just looking at it, it's not just my opinion. They are scientifically looking at a piece of paper and they see their brain and what has happened to their brain. That gives them a lot of insight and commitment towards the treatment. They go after fixing the problem.
Right. I mean, that would be an interesting tool when somebody first gets into treatment, they're in detox, they're just in withdrawal. If they can, as part of their initial residential treatment, not as part of it, but as kind of during that period of time, during that phase in treatment, get that scan and have kind of a baseline of, okay, this is how damaged your brain is now. And then, maybe 90 days later when they've finished 90-day program or when they've, further along in their progress, get another scan and say, okay, well, this is how far I've come. Because a lot of the outcomes that we see are based on subjective criteria. So it's, obviously they're not using, and that's objective, but, they feel better. And a lot of those things is based on the conversation with the client, right? So you understand the outcome based on a conversation, but this is an actual kind of scientific tool that shows the baseline of the brain and the damage to the brain at point 1, and then at point 2, which is, after maybe 3 months away from the drugs and alcohol, and then, with them putting in the time and effort into group and individual counseling. I think that seems like that would be a great tool for them to be part of a treatment program, even for substance abuse or other mental health disorders.
Yes. So throughout the past 18 years, 17 years, I've seen patients, many patients that would come and say, well, I don't think that cannabis has a negative effect on my brain. Right. I just want you to prove it to me.
Right.
So I say, okay, well, go stay sober for a month.
Okay.
Come back, we will do a scan. And then we will scan you when you are intoxicated.
Right.
So, and I've had many patients that will take that challenge.
Right.
They would go sober, we'll do a scan, and then when they got intoxicated, we'll do scan while they are intoxicated.
Right.
And we'll show them the comparison.
Right. It's we're not making this stuff up.
Yeah,
right?
This is something that affects the blood flow of the brain, and there are many studies on this. It's not just, or even regarding the traumatic brain injury. See, when it comes to mild to moderate traumatic brain injury, especially the athletes, football players, and it's very difficult to assess the intensity and the severity of a traumatic brain injury when it's a mild to moderate brain injury, because the CAT scan will not show anything, and the MRI will show a normal structure of the brain. The MRI is only positive when the shape of the brain changes. That's when it shows. So the best tool to determine the intensity of a traumatic brain injury is a functional brain imaging. Whether if you do a functional MRI or a PET scan or a SPECT scan, that's the best tool to determine the intensity, because the blood flow gets affected, the inflammation affects the blood flow. And so that's a very good tool for us to determine the severity of the traumatic brain injury.
Okay.
A lot of athletes, they get the symptoms, but recover in a few days. However, they have had subsequent head traumas.
Right.
That has a cumulative effect, and then it becomes a real problem. But this is a good way to give the athletes an insight about the severity of the traumatic brain injuries. 10, 15 years ago, we got involved in this NFL study. We studied quite a bit of NFL athletes, and I've had many of them complete their treatment protocol, and they've been very successful.
And so with the athletes, so we're talking about traumatic brain injury with athletes, and in your practice, do you see a lot of adult athletes, professional athletes, or do you also see kind of collegiate and especially in this area, we're in, Orange County, Southern California, do you see high school athletes? So what are the different types of sports and kind of the different age groups that you're seeing dealing with these traumatic injuries?
Most of them are within the 18 and plus category, but I've had also, kids 12 to 18 years old that, the parents were quite worried about the continuity of their sports.
Right.
They were like, how adolescents are, they always want to continue to play sports no matter what, how bad. So those are the families that will come and determine the intensity of the injuries that they've had, and then, to develop a treatment protocol.
Okay, and then so based on these studies that you guys have done, what are some of the treatment, what's the treatment plan for somebody with a traumatic brain injury?
So the number one treatment is to prevent further head trauma.
Right.
So we would want them not to have another head trauma as much as possible.
Right.
So giving themselves a break or being more cautious, that really helps. That's number one. Number two, we kind of educate them about the symptoms of traumatic brain injury and the healing process. So psychoeducation is the second part. Treatment-wise, we focus on strategies that will improve the blood flow in the brain. So nutritionally, we develop a nutritional protocol. We consider hyperbaric oxygen treatment. One of the treatments that I've seen quite a bit of a response is hyperbaric oxygen treatment. Certain supplements that like omega-3, huperzine, vinpocetine, ginkgo biloba, alpha-lipoic acid, phosphatidylserine. These are the supplements, and vitamins. These are the factors that will really make a difference. Increases the blood flow to the brain. Regular exercise that will not increase the intensity of the head trauma. We recommend that. Sleep is a major factor. Adolescents especially, they struggle with sleep. So they don't get enough sleep. And the healing process actually happens while they are deep in sleep. Because when you're in a deep sleep at night, that's when the growth hormone secretion happens.
Right.
The growth hormone gets more secreted, and that's when the healing process happens. So we kind of educate them about that. But the most effective treatment is prevention.
Right. Okay. You mentioned earlier that you also work with a lot of ADHD and mood disorders, so I kind of wanted to talk about those topics as well. For ADHD, what age group are you working with?
Well, one thing that we have learned over the past 25, 30 years of practice is that initially we thought that ADHD was perhaps more a children and adolescent problem, but now it's very clearly proven that it's also an adult issue or an adult problem. And, most of these adults, they get kind of at least 30 to 40% of them, they are undiagnosed during their childhood.
Okay.
And they continue to struggle as adults
Okay.
with their time management, planning, organization, their productivity at work. Impulsivity, all of these issues continue to be a problem for them. So that's one thing that we have learned. Number two, from a treatment perspective, many different medications and other tools available. Although the most effective treatment is, ADHD coaching, psychotherapy, and medications.
Okay.
But there are studies now that show that even neurofeedback has, quite a bit of efficacy in treating ADHD children. And again, the main issue here is that you don't want a kid with ADHD to remain undiagnosed.
Okay.
Because if you don't diagnose and you don't intervene, academically they suffer.
Right.
And all the studies show that those kids that academically they don't do well, they are the ones that have the worst prognosis.
Right. And so I think a lot of parents might, think, this is not a serious situation. Maybe their child is struggling in school, or maybe they're having a hard time sitting down doing their homework. And so they just kind of dismiss it as, well, I don't want to go to see a doctor or to see a psychologist or psychiatrist to diagnose this, right? With the idea that they'll just, either grow out of it, or maybe that school's just not the right fit for them. Parents kind of have different ways of handling that, right? But you're saying that if there's any concern, or if there's any identifying factors, that there's even a potential chance that this person might have a hard time struggling at school, the recommendation is to get it checked out, right? And so what does that look like? Let's say I'm a parent, I'm worried that my son is not doing well at school, or my daughter's not doing well at school, and I want to see what's going on. What's the first step?
Yeah. So the first step is obviously to get the report from the teachers.
Okay.
The teachers observe the kids in the classroom, and they, throughout the year, they've learned they can see easily who is inattentive, who is hyperactive, who is impulsive, and so they identify all those factors. So if the teachers are, what they can do is they can complete a Connors report. Connors continuous performance test is, questions like 28, 30 questions in regard to kids' behavior inside the classroom.
Okay.
There's a parent's version of Connors checklist. There's also a teacher's version. So they look at it and then they grade those symptoms: hyperactivity, impulsivity, difficulty finishing their homework, a resentment towards homework or academics, procrastination, difficulty following direction. All of these symptoms, there's like 28 different questions. So the Connors checklist can give us an idea, can give the parents an idea. And if that is a positive finding, then obviously the next step will be to do a psychiatric or psychological evaluation.
Okay.
Once they're diagnosed with it, then generally we try to use alternative treatments rather than jumping into medications first.
Got it.
Like we do ADHD coaching, which focuses on challenges like academic resentment, procrastination, time management, planning, all of those factors. And then we use certain supplements because these kids are deficient in omega-3, phosphatidylserine, and certain other supplements. So we kind of introduce those supplements. Nutritionally, we educate the parents and the kids. Because as you may know, today the diet of an adolescent or a child is very,
not
very
healthy,
poor,
yeah.
and that can affect the whole brain development. We try to kind of be more focused on the diet, exercise, sleep, all of those factors. And if that was not effective, then we jump into the medication. I generally use medications that are less kind of from a side effect profile, have lesser side effect. And then I go into using stronger and more potent medications. Most of the medications are stimulants.
Got it.
Like methylphenidate or Ritalin group, and then the amphetamine group like Adderall or Dexedrine or Vyvanse. These are the amphetamine groups that are a little bit more potent and stronger. And so the stronger ones have more side effects. You would want to have continuous academic evaluations to make sure that they're caught up. You'd want to make sure that you've also treated other comorbid conditions like anxiety, depression, because kids with ADHD, they identify with them. They feel like they don't belong to school, and relationship also gets affected quite a bit because they're the troublemaker. They always, so other kids kind of stay away from them, and
right.
So they find themselves more isolated, and then it becomes a big issue. Self-esteem and self-image gets affected, and so you'd want to focus on that area also to make sure that the kid is not suffering.
Right. So it's really a kind of comprehensive approach to it, and
very comprehensive.
Kind of start with the least intrusive, and then as you kind of build, if there's medication, things like that, you can always add that. But first, a lot of the coaching, it seems like that could be creating the self-esteem, creating the confidence, and then helping them. And it's a team effort, in terms of like maybe they need a tutor. There's other people that can kind of step in and help as well. So what have you seen in terms of, let's say somebody comes to you and you do your assessment. So a parent brings their child, they're concerned about their struggle. You do an assessment, you diagnose them with ADHD. And then, you work with them over a period of time. What would you say after, how long does it take? Is it case by case, or is there after a year, after 2 years? What's the trajectory of working with that individual, and then how much improvement have you seen with your clients over the amount of time that you've worked with them dealing with the ADHD?
If it's pure ADHD, there's a very good success and response. 90% plus response.
Got it.
Yeah.
Got it.
And the main focus is that you want to make sure that the kid is caught up academically. The frontal cortex continues to develop throughout the years. So it may take a little bit longer for the frontal cortex to fully develop, but the response is very good, very positive.
Got it. So you've seen over 90% success rate with just
pure ADHD.
Right.
When ADHD is combined with depression, anxiety, and all these other disorders, substance abuse and all that, then becomes more challenging.
More challenging, because then they have to treat multiple things, and
yes.
There's other damage to the brain that you have to deal with, right?
Yes.
You mentioned earlier about mood disorders. And I wanted to hear a little bit more from you. What is your definition of mood disorders? What are the different things you've seen, and what are the treatments that you've seen to be effective for that?
Yeah, so mood disorders in general, most of it is basically depression. There's severe depression, there's mild depression, and there's chronic depression. There are different types of depression with different categories. Severe one would have suicidal thoughts and homicidal thoughts and psychosis and hallucinations and all that. The milder one, they are chronic and, it's not that intense, but almost every kid goes through a phase of depression, so depression is part of it. This other condition that we usually see in a cyclical mood disorder, which is called cyclothymia, where you have phases of depression with a little bit hypomanic or manic episodes, and then normalcy, and then ups and downs. It's called cyclothymia. We have a disruptive mood dysregulation, which is also in a form like a cyclical mood, ups and down. And then we have the bipolar disorder, which is a more intensive and more severe form of mood ups and downs, where you have a week or two of like really upward mood, where you become manic or hypomanic, and then a crash or a depressive phase where you feel really hopeless, helpless, no energy, no motivation, you isolate yourself, and those are the different types of mood disorders.
Got it. And so in terms of, so those are the different types. As far as the treatments that you've seen to be effective, what are some treatments and tools that you guys use at Amen Clinics and you personally use to treat people with depression and other mood disorders?
So depending on what type of a depression it is, if it's just a simple depression or a mild to moderate depression, we try to use psychotherapy and group therapy, individual therapy and group therapy. We also sometimes use neurofeedback, transcranial magnetic stimulation, that's another treatment modality. And we also use medication. Generally, medications are more effective for kids who are older than 12 plus, and the side effects are lesser. And the main reason for that is that the serotonin receptors, where these antidepressants that we have, where they work on, they're not well developed in children.
Right.
So the response is kind of unpredictable.
Right.
So we try to avoid medication in the first phase. But let's say if nothing was successful then and medications were needed, then we usually use SSRIs, which are selective serotonin reuptake inhibitors.
Okay.
Or SNRIs, which is serotonin and norepinephrine reuptake inhibitors. Under the serotonin reuptake inhibitors, we have like Zoloft, Prozac, Lexapro, Paxil. Those are the common ones. Under the SNRI, we have Effexor, Prestige, Cymbalta. These are the combined ones that we usually use.
Right. Okay. I mean, there seems to be a lot of options these days as far as, what they can take. And then through your diagnosis, you figure out what's the best fit for that specific client.
Yeah, I mean, generally you would want to, obviously each individual has their own specific treatment. Which will incorporate also, family, friends, even school. And so that's, you kind of look into the whole picture. But intervention-wise, you would want, depending on the intensity and severity of the symptoms, you would want to start with milder intervention and then gradually, go to more aggressive treatment.
I think the final question I have for today is really, a lot of times when we're thinking about our audience, and there's people who are suffering with mental health, addiction, eating disorders, different types of maladies, and ultimately we want to use this platform as a resource for them. So they're listening into this and they're learning about these different disorders, different treatments, different tools. Let's say I'm a parent sitting at home and I'm watching this, or I'm somebody who's dealing with a mental health disorder and I'm not sure, if it's a real disorder or if it's not. And I'm kind of just curious, what are some symptoms and what are some things that, they can observe, whether it's their child or their brother, sister, parent, on a day-to-day basis that would then spark, hey, I should go see Dr. Darmal, or I should go see another psychiatrist to get a little bit more information about this.
Yeah. So let's say each disorder specific intervention.
Right.
So let's say parents who see a kid with ADHD, they kind of try to avoid any kind of evaluation.
Right.
Clearly the kid is going to suffer. Academically, they will suffer. And because of impulsivity, they will get themselves into trouble. As substance abuse becomes the main risk factor. At least 40% they get into substance abuse. And the ones that get into substance abuse are the ones who don't do well academically. So academics are very, very important. If you see that the kid is getting into trouble, they're very accident prone, they are not doing well academically, that's a definite reason to start evaluation and treatment.
Got it.
And if it's depression or mood disorder or anxiety, for example, that's also a very important part, because a lot of parents, they're under the impression that, kids, they don't get depressed. Or the depression in children is temporary, it doesn't last that long, it's just a circumstantial situation. That's not true.
Right.
Kids, they are genetically prone to develop depression, and environmentally they're prone to develop depression. Their depression presents differently. It's not just the sadness. Their depression may present with irritability, anger, aggressiveness, impulsivity, not doing well academically, just being isolative and not interacting with parents by itself could be an indication for a possible depression. So this idea that kids never get depressed, that's not real.
Right.
They do get depressed, and depression could have really damaging consequences.
Got it. No, thank you for that insight. So if you're watching and you're listening, I think one of the key takeaways from today, first of all, we learned a lot. And thank you so much, Dr. Darmal, for coming and visiting and sharing all your knowledge over the last 3 decades with us. But ultimately, I think one thing I want to focus on, and I want the audience to focus on, is let's say you have a child and whether they're in their teen years or even earlier childhood, or even if they're adults, young adults, and you're concerned about that child, it's not something to blame yourself about, to blame your spouse. Like Dr. Darmal said, sometimes it's environmental, sometimes it's genetic. So blaming yourself, blaming your spouse, blaming your child, that's not the answer. Getting angry about it, getting frustrated, that's not the answer, because none of these things are going to lead to some form of resolution, some form of treatment, right? And so the more you're angry and the more it becomes about your feelings and kind of personalizing it, the least likely you are to actually seek help or have your child seek help. So I think the better thing to do is really just saying, hey, look, we don't know what this is. It might be something, it might not be something. Let's get an evaluation. It's not something to judge yourself or judge other people about. And then take that first step. You take that first step, you get an evaluation done. It might be nothing, it might be something, it might be very mild. It might be something that with just a little bit of coaching, a little bit of therapy, you can overcome it. And if it's something that's more serious, then at least you've caught it at an early age and you can start working on whatever is necessary to mitigate any damage associated with that. So your child or your young adult can have a very productive life and not be limited by any factors that result associated with these issues. So I think that's really, early intervention is key, and don't blame yourself about it. Just seek the help and move forward.
True.
Thank you again, Dr. Darmal.
My
Thanks, everyone.
pleasure.